am Dr. Curtrina Strozier, as my mother introduced me. I am an obstetrician and gynecologist, which means I deal with women mainly, and specifically preventative medicine is a main bread and butter of what I do as a gynecologist. I know that there might be some men on here, and no, I don't take care of men. However, the principles of what I'm discussing today are applicable to male and female, as well as the pediatric population. So I'm glad to be on here speaking. Okay, so what is preventative medicine? In general, preventative medicine is the practice of promoting preventative health care to improve patient well-being. The goal is to prevent diseases, disability, and death. Preventative medicine specialists are licensed medicine doctors that consist of medical doctors. Also, you have DOs. You have a host of mid-level providers such as nurse practitioners. You might even have physician's assistants who may see patients for preventative medicine. You might also have midwives in the gynecological setting who might provide annual wellness visits. What you should know is that there are a lot of different organizations in medicine that create our guidelines. So, for example, primary care doctors, which are your family medicine doctors, they usually follow the U.S. Preventative Task Force. I'm a member of American College of Obstetrics and Gynecology, and there's the AMA, there's the American Cancer Society, there's the Surgeons National Network. You also have National Radiology College. There are a lot of different medical societies that look at different research that's done. So when you're thinking about this word that we use in medicine called evidence-based medicine, when we think about this word evidence-based medicine, what does that really mean? In a nutshell, it just means that the doctors are practicing the research-guided evidence. There are various studies that are done based on research that we might get from other countries. There are clinical trials that are performed, and based on those findings that can be reproducible for years, those get implemented into the practices. So if you are thinking about a doctor and you're thinking about what is the best doctor, you want someone who is practicing evidence-based medicine. So we know that one of the barriers to starting your healthcare is actually the mistrust of the medical community in communities of color. This was started way back in slavery. We do know that there are clinical trials and studies that were performed that were unethical, and it does have a negative stigma on the medical community. It is also an issue with education. We know that in years of the early years of freedmen, where education for people of color was a barrier, the medical schools that people of color were able to attend did not have adequate supplies. Oftentimes, when they would receive supplies, they would be raided. So it made it very difficult for our young aspiring physicians to have access. I will just start by speaking on some of the well-known issues with studies on human subjects. We know about the Tuskegee syphilis study. This is one of the major issues that people of color have a mistrust for medical community. The timeline of this is that there was a study that started in 1932 by the United States Public Health Service. It was done in Tuskegee, Macon, Alabama, where subjects were inflicted with syphilis and not made aware for 40 years later, even in spite of the fact that a treatment of penicillin had become available. Those subjects were not treated and were not informed. It was only until 40 years later that that study became public knowledge, and those patients were then offered treatment. If you can imagine the soliloquy of families that may have been affected, women, wives, children that may have been affected by syphilis during that time, it is overwhelming to know that there was something less than 100 years ago that occurred in this country against people of color. It was only in 1997 when President Clinton gave a formal apology to those families. This one kind of hits me hard. The father of modern gynecology's name is Sims. This physician was well known, received many accolades in the medical community. He was a gynecologist who did research on enslaved Black women without anesthesia. It was a huge issue with medical ethics. Historians said that he did his surgeries on enslaved Black bodies because his racist views let people believe that Black people did not feel pain. That is a hard pill for me to swallow. And living in the South, he was praised at the time. I think, of course, contrary to his beliefs, a lot of people were kind of finding those things were grotesque, but he actually was the president of the American College Association, the same people that boarded me. And so as a woman of color, I'm a patient too. As a woman of color, I am a U.S. citizen who has the history of slavery that oftentimes can be pretty oppressive. So it was pretty alarming to me to be a gynecologist and use a Sims speculum, in which that's what it's named after. It's a pretty insulting history. But what I can say about it is those lives that were lost in those studies are also our teaching patients, are also the legacy in which we have so much medicine that we can practice today. And because of those studies, because of those trials, their deaths and their suffering is not in vain, because I still am able to stand here today, years later, as an OBGYN of color and take care of patients of all colors. So there is progress in our country. There is progress in the medical field. So it's just one of those things that has a negative stigma, but we have come so far. So we are so grateful and we thank God for that progress. Another area, Gila. You might have heard of the Henrietta Lacks story, and her cells were harvested in Louisiana, where she had a rare mass on her cervix. Her cells were taken into a lab. They had never seen these cells reproduce so quickly. Well, to make a long story short, she had a very aggressive cervical cancer that led to her death in her early 30s. She had 4 children, and this story came to light when I was at Morehouse School of Medicine in my residency program. I was working under Dr. Roland Patillo, who was our GYN oncologist at the time. He was an intern at I can't remember which university in Louisiana, but he was an intern and he met her. He got in contact with her family and was alarmed to know that her 4 children did not have health care. They didn't have medical health care for regular preventative services, but her cells have produced so many vaccinations. Her cells are in every laboratory in the world. So our work, even when people didn't have recognition, even when we didn't get any kind of reimbursement or reciprocity for the things that we encountered in our people of color, our story is still successful. These people have legacy. And so I'm so grateful for these stories being brought to light. And one of the things I can say is, just because we have this negative stigma of these bad examples, there are people who are trying to make things right. And what I can say is that due to these types of experiences being brought to light, there are laws that prevent these types of things from happening to humans ever again in our country. When we start medical school, the whole Hippocratic oath is to do no harm. And we spend a significant amount of time when we are in medical school going through various cases that might have ethical issues, moral dilemmas. We also have to be very cognizant of um, cultural, spiritual, and all kinds of other differences that may influence people's decision making when it comes to their health. You have people who are not 100% on with Western medicine. They like alternative medicine. You have patients that come from other countries that do a lot of holistic approach. Just because we have a diagnosis and a recommended treatment plan doesn't mean that we could force someone to accept that treatment plan. So patients have autonomy. There are a lot of rights. And so I'm so grateful that I work in a field that is progressive, also cognizant of the differences in our patients, our patient population, our communities, the access that we have, whether that's social, economical, and just ultimately having an idea that, patients have the right to choose what they will and will not accept. So, one of the biggest things when it comes to your healthcare is making sure that you are comfortable with your physician. Your patient-doctor relationship dictates a lot about what you are exposed to, what you understand about your health, what you understand about what you should be doing, what you should be screened for. And so to me, when I see my patients, when they come to see me, it should be like a conversation. They should feel comfortable. And if you don't have that comfort, then you may consider either being a little bit more open or asking more questions or just kind of testing that relationship a little bit more with the current provider if you really like the kind of service that you're receiving. But if you have a concern about your relationship with that provider, you may want to find somebody else who is a better fit for you. It does matter. For the most part, when you're thinking about your relationship, just like with any other relationship, there should be open communication. You should not feel uncomfortable asking your provider any question that comes to your mind. You should feel comfortable with the kinds of recommendations that you're receiving, that you understand what you're being told. You should also make sure that if anything is confusing, that you have printed information or other ways to understand what is being told to you. You should also feel confident in the plan, and you should also understand that these decisions you make with treatment or receiving medical care should be a joint decision. There are times I have patients even in my family who I don't necessarily see on paper, but I tell them that they should have a colonoscopy at age whatever. And they're just saying, look, I can't do it. I don't want somebody else's scope going inside of me, blah, blah, blah. And I try to give them all the medical reassurance, but it is still their decision. So at the end of the day, as a provider, I make a recommendation to my patients. I allow them to talk with me about their concerns, ask their questions, and we can come up with a joint decision making about what needs to happen. Other things, as we are talking about your wellness visit, you should have a wellness visit once a year. The wellness visit is usually covered by most insurance companies without a copay. It is kind of like, we want you to be healthy. We want to know your overall health. We want you to know your overall health. And we want you to do the things that the doctors recommend. So therefore, a lot of insurance companies will provide this service free of charge. You may not have a copay or anything like that. And if there are specific tests that are recommended as a part of your wellness based on your age, based on the information you give the doctor, some of the subsequent testing should also be covered under the wellness charges if the doctor is using the appropriate code. So for example, if your mammogram is recommended, if you don't have a copay for preventative services, then you may not have to pay a copay when you go get your mammogram. However, if it is a problem versus just a preventative there are different codes that we use based on what we see. So if a patient has a normal exam, a normal breast exam, then I'm going to order screening mammogram as the diagnosis. However, if I find a mass or something else on exam that's going to prompt more than just a screening mammogram, and instead you need a diagnostic, this is a different test, and therefore it may be subject to a copay, but you much rather have a better specific exam or study performed based on what's found. So other things, for example, if your doctor diagnoses you with obesity, as an obese patient, you should have your cholesterol checked. You should also have your sugar checked. You should have your thyroid checked. So some of those things should fall under wellness, but some others might fall under a diagnosis code. And so making sure that if you ever receive a bill for some service that you feel like should be covered, you might just want to swing back to your doctor's office or talk with somebody in billing and coding to make sure that the appropriate codes were used for your services. Something that is very, very important when you go to your doctor is to bring a list of your diagnosis. When people are young, they may not have a long list of diagnoses. However, as you get older and your list grows, it's important to know those things. And at some point, you may not be well enough to tell somebody your medical history, and so it may be good to have it on a printed laminated card. All of the diagnosis, all of your surgeries, any hospitalizations, any medications, and the medications that you take, we need to know if you take certain things over the counter that are just quote unquote supplements, because some of those supplements, even something as much as a baby aspirin or black cohosh or something else like that, those things can interfere with other medications that the hospital is going to, they may, want to make sure there's not a drug interaction. So everything you're taking over the counter and everything that is prescribed, you need to have it listed, as well as the reasons why you take it. If ever you are involved in a situation where maybe there's a stroke, and God forbid, we don't want anybody to have those issues, but you should have that listed so that any care providers, any family members that might be nearby will have something like that to provide. If you have more than one provider, such as a cardiologist or a nephrologist or a neurologist, if you have multiple providers, you should have that listed, as well as their contact phone numbers, so that if ever you're admitted to the hospital, we have access to that. When you go to your wellness visit, part of your exam includes your blood pressure, checking your heart rate, your respirations, and the oxygen saturation. You may or may not have a urinalysis and a hemoglobin point of care testing, the little prick on the finger. We do what's called a review of systems, where you answer a form that's like a whole lot of questions all over again, like any headaches, blurry vision, runny nose, cough. You have to answer those as part of your wellness visit. And that kind of gives us a prompt if there's anything wrong with a specific group, that we will kind of make sure we address those issues as well. When it comes to your physical exam, we look at your overall appearance. And in our opinion, what we look at is, do you look well today? Are you well groomed? Did you get up? Did you comb your hair? Did you put on clothes? Sometimes, as people are having alterations in their mental status, they may or may not have gotten dressed appropriately. Maybe shirt might be on backwards, or maybe the buttons may be extremely off. So when we're looking at general appearance, do you look like you're aged appropriately? Are you aging quickly? Do you look older? Do you look younger? It gives us an idea as to your overall wellness. We look at your head, neck, cardiovascular, your lungs, abdomen, neurology, psychology, as well as your mental health. You might have a mental health screening. Oftentimes we are screening for depression and suicidal ideation, and you will actually probably see that very common at every access in your healthcare. So you go to the ER for a cut thumb, and now they're asking you about, are you suicidal? It does seem crazy. So other things that may be a part of your wellness visit will be labs. I had mentioned having cholesterol checked, your thyroid, your overall metabolic panel, which will check for sugar. And there may be some imaging that's also recommended, such as mammograms for women based on your age and based on your family history, as well as a colonoscopy, DEXA scan, which is looking at your bone density. And then also, your doctor should review vaccinations. So, as a part of owning our health, we all know we talk about a balanced diet. You can talk with your provider about what they recommend as far as how many calories you should have based on your height and your weight. You can also talk to them about your BMI and what you can do to reduce it or to be in a normal category. The recommendation for exercise is 150 minutes of moderate to minimal to moderate activity or 75 minutes of intense exercise per week. And also, we really have to put a big emphasis on owning our mental health. A lot of patients struggled with COVID and the major changes of being home, or just the major dynamic changes of life being shut down, things being different. And so making sure that we're staying spiritually grounded, meditating, reading, doing the things that make us feel good about life, those are really important with owning our health. So just in general, there are some special testing, and the Pap smear is usually started at age 21, and it continues to age at 65, we stop. However, if you have abnormal Pap smear at any point, the recommendation is to continue it for 20 years after the last abnormal cells have been obtained. Even if you had a hysterectomy, but your hysterectomy or your Pap was abnormal, there's still supposed to be a Pap smear of the vaginal cuff. And so that brings up a really good point, because a lot of women feel like once they've had a hysterectomy that they no longer need to go to a gynecologist or to have a pelvic exam. You can't get rid of the duckbill or that SIM speculum we talked about, because there are vaginal cancers. There are also vulvar cancers. So a hysterectomy does not get you out of the box of getting an exam. I have diagnosed an 88-year-old woman with a vulvar cancer. She just started having a little irritation. I mean, how many times do women have an irritation? You probably come out your mom's womb with an irritation in your vagina, because that's how many times people talk to me about vaginal irritation. It's just the itch, it's something that's like anything, but for her, she knew it was different. And she was wheelchair bound, and so getting down there to look at it was not something that was easy. But she admitted she had not seen a gynecologist in probably 20 years, but something was not right. It felt like it was where the kids split her in the hoo-ha, and it was an itch, and she needed it looked at. Opened it up, and it was a vulvar cancer. So that's just something that we have to be cognizant of. As far as breast exams, from the time the girls start getting breast tissue, they should have what's called breast awareness, which is about every 3 months. They should just feel the breast after their menstrual cycle to feel for any lumps or bumps. They need to get acquainted with what's normal breast tissue. And during the exams, even starting probably about 13 to 15, they should have a breast exam done at their wellness visit. If it's with the pediatrician should do it. If a mother has allowed their daughters to start seeing a gynecologist, and the gynecologist will do a breast exam once a year. As far as mammogram, the recommendation from FACOG is to start annual mammogram starting at age 40. Now, the U.S. Task Force, they say every 1 to 2 years for a mammogram. When we come up with these guidelines, the guidelines are, one, to find a time that is going to catch 90% of cases. But we also are trying to minimize costs. So you can see why maybe U.S. Task Force is looking at the cost of doing a mammogram. And then also sometimes people find something and it's an overread, but you come back for a biopsy, and that's actually getting people more anxious. It also might increase healthcare costs. So they went with 1 to 2 years. We say every year because we know that with early detection, breast cancer is 100% treatable if you catch it early. So that's why we say yearly. Now, if there is any breast cancer in the family, the recommendation is to start the breast mammograms 10 years earlier than the youngest diagnosed patient. So if you have a family member who had breast cancer at 37 when they were diagnosed, that person, the family member should start getting breast cancer screening at age 27. Okay? Prostate exam starts for males during their annual visits at age 40, but if there is prostate cancer, they're going to start it earlier. Colonoscopies. This one is controversial in the fact that it used to be age 50, and I am telling you, across the board, it has dropped to age 45. So if you have not had a colonoscopy, that is looking for the smallest dimple polyp to detect colon cancer early. African, somebody is on here. African American patients are 10 times more likely to die from colon cancer in comparison with whites, mainly because of the late diagnosis and advanced disease at the time of diagnosis. So this is something that we really should be taking care of. There are alternatives to having a colonoscopy. There's a test that can be sent to your house. It's called, I believe it's a Cologuard, a Cologuard test where they are actually taking your entire sample, looking for your actual cells. They're not looking at your stool. They're looking for colon intestinal cells on the stool sample that they can look to see if they see any atypical cells. So the good thing is it screens. It's not as good as a colonoscopy, but it screens the cells. If there are any abnormal cells, it doesn't tell you that you have cancer or a precancer. You still will need to have the recommended colonoscopy because that's a visual look at the intestines and any biopsies of any abnormal appearing tissue to actually screen for precancers and cancers of the colon. The little stool cards that the doctors do, it helps. It tells us if there's blood, but it doesn't really tell us if you have cancer. As far as other testing, we check for cholesterol, we check for heart disease. Oftentimes, if there is a family history of heart failure, heart attacks at a certain age, if you report that to your doctor, it may prompt additional testing. If you have symptoms of heart disease, it may prompt additional testing like an EKG or a stress test. You should also have screening for smoking cessation at every wellness visit. There's also screening for depression as well as substance abuse. Intimate partner violence is also a screening, as well as elderly abuse. In the younger age group, STD screening is recommended up until age 25, routinely with an annual. And then lung cancer screening is also recommended for smokers. One of the biggest things that I think is key with talking about our health is that for a lot of generations, talking about our health was considered a faux pas or it had a negative stigma. It is okay to discuss your medical history. I think oftentimes people don't want to tell somebody or their family members that they have a medical issue because they don't want them worried about them or being concerned, or, oftentimes we just don't want people to worry about us. However, the conversation is not so much that people can worry about you. We also can make sure that you're accountable, but we also can make sure that if you have siblings who somebody has a blood clot disorder or somebody has diabetes, they might be able to say, hey, this medicine didn't work. Maybe those conversations can save time with getting you better complied on different medication treatments. It can also help the next generation of family members to know the things that they need to be screened for and that they need to be cognizant of. I think a lot of times people don't report medical issues because they might be concerned about the increase in their healthcare insurance costs, or might be concerned about life insurance policy costs. However, I have seen more help being done than harm on the back end with life insurance policies. I'm not sure exactly how much more expensive they are, but that is a thing that a lot of times people do worry about. From a medical preventative point of view, if you, for example, are at a higher risk of having breast cancer, we know that there are screening tests such as genetic tests, such as BRCA tests, where we could get your blood drawn, send it off. And if you do carry a mutation for BRCA or Lynch, that allows insurance to cover the cost of getting these preventative tests that usually start later on in life to doing it earlier. If you just because you're born with a DNA that might have you at higher risk of a cancer doesn't mean you have to die from that cancer if we could just detect it earlier. Or they'll give you better imaging. So instead of just getting a mammogram, you might get a breast MRI if you're a BRCA carrier. So there are pros and cons when we are thinking about this, but overall, a family discussion about your medical issues helps us to make sure that the next generation can report those to their providers. So if you have heart attack, heart disease running in the family, I'm not going to tell my doctor, no, there's nothing that runs in the family. We all healthy. No, we have heart attacks in our family starting at age 40. You know what? As a gynecologist, I'm not going to let you stay on birth control pills past 35, or we're going to have a talk about what's going to be the better approach, because now I have a heightened awareness of medical issues that might affect you earlier than the general population. So we do medicine that's general, but we also individualize your healthcare based on the things that you tell us. So in conclusion, there is a lot of there are a lot of things that I've discussed today, including some barriers, the negative history, and the medical community. But I have also talked to you about your preventative wellness visit and some of the things that you can do to keep yourself healthy, as well as challenging your provider to make sure you have the best care that you are needing at your wellness visit. I'm open to questions.
Thank you. And I'm trying to get mine in quick, but so I don't keep coming back and forth. I'm going to ask you these questions. You can write them down and give me your answer. In your presentation, one of the things you said is list of all diagnostics that you've had previously. I didn't never hear that before. And I thought that most doctors were able to have access to your records without having to ask you that question. That was one. Number two, you said a list of all medicines being taken, which you included over the counter. And I always thought it might have been what was prescribed to me. The third one, you spoke of a person's appearance. I was just being funny when I wrote that down, because a lot of people today in this generation go out in their pajamas and everything else, and to me, and their appearance looks terrible, but I think they have a psychological problem. But the last one that I'm concerned about, and I can never get anybody to understand when I say this, you said a balanced diet. Most people today don't have an idea what a balanced diet is. They only think of meat, potatoes, and pasta. That's everywhere I go. I'm a greens person, vegetables, fruit. I like that. Those are the four things I'm concerned about that I'd like for you to address and give me your response on.
Okay, these are all very good questions, and I'm glad that you asked. So the list of diagnosis, so that's any chronic medical issues that you had. So for example, you were diagnosed with high blood pressure, but you lost 20 pounds, and now your doctor took you off your medicine. You still have high blood pressure. It is diet controlled. And the reason why you should still report it is because the 20 years that you had high blood pressure, that you were on medication, it still affects your blood vessels. It affects your brain. It affects your heart. So if you hit age 65, if you have special recommendations for people that have high blood pressure, that high blood pressure people that don't have high blood pressure would not necessarily have a new recommendation for EKG or a stress test, you have removed yourself from screening something that you still could be at risk of heart disease.
Well, I have heard this statement made. I ain't telling that doctor everything. I don't know if you've heard that. I have heard that.
And
Ain't
I
it,
don't
they
get
don't need
that.
to know that.
So that's part of the mistrust of I don't know why someone would not want to tell their doctor everything. It's almost like I'm going to provide you this is what it makes me feel like. I want you to investigate the who murdered that family member, but I'm only going to give you part of the truth. I'm gonna hold this other part and let you figure it out. It is going to delay treatment, it's going to delay diagnosis, and it could affect other things. So I don't recommend not telling your doctor everything. As far as access to records, that's a really good point. This is one of the major issues that drives up healthcare costs is the fact that we all have different medical systems, health electronic records that we use. I don't know of anybody who still may be on paper charts, but you can imagine if your doctor's on paper charts, they get labs that come only to their office. Now you're in the hospital at hospital A. You just had labs drawn 2 days ago. If your labs were accessible to that hospital, they could have those immediately and see if there are any changes, or at least kind of have a starting ground. If you come in a full out, I don't know, asthma exacerbation or heart attack or kidney failure, they'd be able to compare those labs. So part of the major goal with connecting electronic health records is to get the systems to talk. And some of the things they want to make sure that the systems talk to, especially getting information from a hospital, if you were admitted to the hospital or if you went to the emergency room, to get your vitals and to get your lab work and any studies done sent to your primary doctor. So that decreases costs. I can't tell you how many times people come to the hospital and we have to repeat labs just because we don't have access to it on a weekend or evening. But especially in obstetrics, when we have moms come to the hospital, we want to make sure that those STDs are not affecting a newborn baby. But those tests can be very expensive. So we're thinking about the cost driving up. You are absolutely right. It would be nice if all the doctors everywhere you went had access to all of your medical diagnosis. There is something called a legacy or relay system where a lot of your major hospital institutions will report information into a system. And if different healthcare provider has a relationship with that system, that's a national system, there may be some things that they can obtain that cross the system, such as diagnosis, maybe surgeries, some of your immediate information like your name. So there are some things from like the registration side that communicates, and there's some things from the health side that communicates. And you may actually be signing paperwork that tells you that some of these systems talk. So if you show up somewhere else, you're giving permission. That just allows us to take better care of you. If there are labs that can be shared between hospitals, that helps us take better care of our patients. The other question you asked about medications, over the counter you'll see oftentimes, do you have any allergies? Do you have any drug allergies? I've had patients say that they were allergic to bee stings. Not anything I know that we administer has bee stings in it, but there are some patients who are allergic to certain foods, such as apples or eggs. The eggs can be a trigger for certain vaccinations, an egg allergy. So even though that's, not a drug allergy, it's still an allergy. In the same way with your medication list are the things that your doctors prescribe you, as well as the things that you're taking over the counter. So for example, if you come into the hospital with a broken bone or you need some kind of surgery, if you don't report that you're taking a full aspirin every day, and you go to the surgery and you're bleeding, that doctor has not had that insightful information. Then you're bleeding and hosing, and we're like, wow, we would never have cut this patient. We need to get these extra blood products to help reverse the effects of the aspirin. Something as simple as aspirin over the counter. I have patients who take goody powders. That's a combination of anti-inflammatory, non-steroidal inflammatories, but it also can cause patients to bleed. So I get into surgery, I'm in a hysterectomy, and I'll go to clamp down, and this blood vessel pops open. Well, I'm bleeding more than I had anticipated. Patient didn't tell me she's been on any medicines that would cause her blood to be thin like this. Now I'm giving a blood transfusion. I go out to the family and say, hey, so surgery went well. However, we lost a little bit more blood than anticipated. Are they taking any medications, blood thinners that they didn't report? Oh, they be popping those goody powders all day and all night. She get a headache, she pop a goody powder. That is important. You can buy medications that actually harm you in a state where you're not reporting it to a doctor, especially a surgeon. And your last thing, personal appearance. You are absolutely right. So there's a huge controversy. I did a post about the head bonnets because a lot of people think it's appropriate to wear in public. I have one of my doctors who used to have a post when he had his own private practice, and he said no head bonnets, no pajamas, and no head scarves, no hair rollers. And people that saw him that were in the community, people of color, they respected that dress code and they understood why I was there. They, embrace an appearance for coming to your wellness visit. I'm not talking about you're sick and you just rolled out of the bed because you've been bleeding and now you're seeing me because you have a problem. We're talking about I plan to get up and come to my once a year visit and look this way for my doctor. It tells a lot about it, if you have a headscarf on. Now I'm a black woman. I know that it's controversial. It could be a headscarf that's actually decorative and that was your look for the day. But it could be that head bonnet that's got 1,000 grease stains on it and you just didn't get your hair done. It could tell me if there's a financial issue. Girl, why you got that bonnet on? I'm comfortable asking that, but the white doctor might not say, girl, why you got that head bonnet on? For me, she's going to say, I am in the process of taking my hair down and I didn't have time. I'm going to the shop. I'm so sorry. Or, you know what? I'm embarrassed. We don't have running water. That gives me an opportunity to assess the psychosocial issues that I then can provide resources for my patients. Now, that balanced diet, that's a whole nother conversation where we could really have a whole talk about how many servings of protein, how many servings of vegetables and fruits and breads, how all these nutritional things tie into a balanced diet. That's a whole nother lecture. Next question.
Dr. Strozier, I'd like to ask if the EMR system has been completely finalized. I remember in 2013, they had given a deadline, and I was just wondering, they kept on pushing it out. Do you know what I'm talking about?
So there are some recommendations across the board. What she is saying is that there were some national guidelines that required all physician groups, any medical entity to convert from paper to electronic medical records. There were a lot, and that was a big deal because if you were close to retirement and you've done well on paper and you fax things to the hospital, you have had a well-oiled system. And if you don't type and if you're not very computer savvy, there were a lot of physicians that may have practiced another year or two, but if those guidelines, if they could not convert, and it's expensive, you have to buy an EHR.
Mm-hmm.
And you want to, oftentimes if you buy the cheaper ones, it may not work as well. You might have a lot of problems. You have to train the provider, you have to train your staff, and you have to train your team that does your billing on this new system. So there were phases of care that required every entity to convert, and the conversion was done in stages. So like, let's just say, for example, they may have given leniency to just say, these parts of the medical record have to be electronic. And then we're going to give you another 3 years to convert it to all of your system has to be electronic. Doctors' offices were given maybe some kind of supplemental information, or they may have incentivized it somehow, maybe with billing or taxing during that time, but you also might have gotten penalized if you had not converted within a certain time. So there are phases. There's ongoing merging of different systems. It is not a complete task. And when we're talking about completely integrating healthcare, there are goals. And I think most hospitals are electronic, and the mandatory reporting items have been pretty much I think there are phases. So it's not completely integrated, if that's your question. No, they're still working on it. It's a work in progress. And it costs money to do these things. But the
Right.
goal is really to make the systems talk to each other, to
Right.
overall improve healthcare for the patients, but also decrease healthcare costs by not duplicating services, such as a CT scan that might be $3,000. You go to the next hospital, they don't have access to that, and they would repeat it. So you're absolutely right. As far as those things, that's that legacy system that I was talking about. And I believe that most hospitals are communicating, but there are so many drivers, such as this hospital group has been purchased by this for-profit entity that may not see the benefit of spending money in these different areas. I think most hospitals are compliant with the national recommendations, but every hospital does not talk to every hospital. So no, it's still a work in progress.
Right. Because I noticed that you can go to, for example, University of Kansas, KU, and you can go to St. Luke's, and they are not talking to each other. You know,
Mhm.
you'll leave there and you'll say they might ask you, "Did you have such and such test?" And you say yes, and they just slightly just overlook it or ignore that your answer because they know that they have not connected into that system that was called Genius MD that
Mhm.
was supposed to integrate everybody. Um, so they're not,
I'll tell
and
you.
I'm surprised that this is happening. Here we are almost 10 years later, and because of, I want to say doctors, but anyway, but certain entities, you follow me,
No, I follow
only,
you.
yeah,
It's
so,
very frustrating. It is
yeah.
extremely frustrating. Now I'll tell you, I have worked for and this is a prime example. I live in Columbus, Georgia, and I work for in our city, we have two major hospital systems. And
Hmm.
because I delivered babies at both of them, I had access to both, so it made it easy. But for providers that didn't have that access, it makes it very difficult for us to take care of patients in those cases. Now, I'll tell you, they do have a way where probably the information is being dumped into a place in the chart, but the way it's being inserted into the chart, it's not very easy to access it. So,
Hmm.
for example, the chart, and I've worked at St. Luke in Kansas City, and I went to school at KU. I know their charts, but there's something where you have to click outside of the main chart, the format that you're used to looking at, to try to find other information. And it may be dumped into a file that just has numbers. It may not be easy to read. It may not be like CT scan. It might just be a file with some numbers, and you have to click on each one. And it might just be a hemoglobin. It might just be a blood type. It might be your actual whole report of a CT scan. It may give you a date. It may not give you a date. It may give you a wrong date. It may, just because the way that the things are configured to talk, it is very difficult because there are so many different electronic medical records, and you have to have the infrastructure on the backside that is just trying to get the electronic record to the right chart. When we integrated my one hospital that I'm at, we had a hospital ER that was on one system because that's the best ER system. Then when the patient gets admitted to the hospital, the actual inpatient side was on this system. And then they had subspecialty groups that they brought on to the hospital, but OBGYN likes this record, surgery likes this record, orthopedics likes this record, cardiology likes this record because it helps us to do our job that quickly. When they converted us into one system as a whole entity, they took 5 different electronic medical records and made it into one. So in dumping that information, we had patients that had 5 different charts. And then we have to merge them and figure out which one was the correct one. Some things were on the chart duplicate. So it is not a very easy fix. You may even have had a woman who has been married multiple times with name changes have a huge amount of chart over here, but because it recognized the social security number, they merged into a way where you might have lost some data. Or now you come to your appointment and they're bringing up an old last name. Could you imagine somebody who's been divorced or remarried 3 times and we call you that name that was 3 husbands ago? So it's not an easy it's an ongoing process. But if you now add a layer of bringing in a chart from somewhere else with the name, with the maybe it's a wrong one number off on a birth date or one letter off on a name, that chart could be sitting in cyberspace waiting for a chart for somebody electronically to say, oh, I think this chart goes with this person. I've had data imported to the wrong chart with the chart merge because maybe the same date, or imagine twins. And then sometimes insurance companies have the wrong date of birth. The hospital has the right name, date of birth, but in order to get your service taken care of, they have to change the date of birth to get the billing done, and never gets changed back. It's a lot of drama with healthcare records.
Right. Thank you.
You're welcome.
We can't hear you, Al.
That problem you just mentioned, we went for insurance for me. And I had an insurance company call me and tell me, well, your doctor diagnosed you with emphysema.
Ooh.
I said, I don't have no emphysema. But it did cause me problems and rejections on selling the insurance policy or something. And I'm sorry to hear that. I didn't recognize all these problems. I can understand the problem that it could make, and I can understand why it's so important for us to be more proactive in our information to the doctor. But as a Black family and living in a Black culture, we really never had that complete trust. And I'm glad that you're a doctor in the family. You make it accessible for us to talk with you. There's some things now I understand I didn't understand before because of your communication with us. But I'm sure I'm not the only one. But I was highly irritated to be able to get for them to tell me that was my diagnosis, and it was never diagnosed to me that I have it. I don't smoke. I'd never had it. But
it got put in your chart somewhere. Then insurance said something. So I guess if you encounter an issue like that, the best way to approach it would be to ask the insurance company, where did that information come from? On what date of service? And then trace it back to the provider. And then make sure that you contact that provider or that hospital and make sure that that gets removed from your chart.
Okay, I have a question.
Okay.
I have a question about preventative medication.
Okay.
And where doctors want to give you medication based on maybe family history, and then maybe find out maybe 3 or 4 years later you're taking this medication, and all medications have a lot of different things in them. They have different side effects. And then you find out 3 or 4 years later that that medication's been recalled, or they don't want you to take it anymore. Why does that happen?
So what I can say about that is that we practice we call practice of medicine. It's constantly evolving. So today, our recommend and that's we all kind of throw our hands up at COVID. You guys have seen how quickly the COVID vaccine changed. So just imagine we're dealing with multiple medical issues that are being studied and researched. And some of the recalls on medication come from either a contamination or maybe someone has been doing an ongoing study looking at long-term effects, or maybe let's just say, for example, a common one would be lisinopril. It's a blood pressure medication that is used, but we have known medical knowledge that it can cause a chronic cough because of angioedema. So, for example, it probably was, different side effects that are common are probably discussed at the beginning of when you've taken that medicine, and it's been 5 or 10 years, and you've forgotten. Oh, I forgot back 5 years ago, 10 years ago, my doctor said if I got a cough that wouldn't go away, I might have to stop this medication. And so it might not be that medication is a bad medication. It might be a known side effect. However, there are some things that, for example, a common thing that I prescribe for patients, especially young patients, people have menstrual cramps. And I might prescribe an NSAID such as ibuprofen, the prescription strength, or naproxen, that's his prescription strength. I might get a letter as a provider that anybody you've prescribed this medication to, we can see in the pharmacy systems that this patient, they won't tell us a list of patients, but they will tell us that your name has been associated with a medication that has been recalled. So me prescribing the medication is not incorrect. It might be that pharmacy had an issue when they look at, not the pharmacy itself, but the pharmaceutical company, when they go back and look at the batch of medications that might have gone out, maybe there was contamination. Maybe somebody put the wrong dosing, and therefore, as a result, they might have got some complaints that people are ending up with kidney failure. Did I cause kidney failure? I prescribed the medicine. Did the pharmacy do a wrong thing? They put out the medicine that the pharmaceutical company sent to them that's supposed to be dosage X. So this way you end up with these class action suits. Or some things just may be that as you age, you're at higher risk of a side effect from a medication. Something as simple as metformin can cause a bump in your creatinine level. It's a known side effect. Is it the chicken or the egg? Was fixing your sugar helping improve the functioning of your blood vessels? You've had improvement, but as a side effect, that medication could also maybe affect your kidneys. But let's just say you haven't been on that medicine for 5 years, your blood vessels might have more atherosclerosis, which is accumulation of junk in your vessels, and then you could have kidney failure because you can't get enough blood flow through that blood vessel. So it's a chicken or the egg. But I think there are a number of reasonable explanations as to why something might be stopped.
Dr. Strozier, I have a question.
Okay.
What is your opinion about Eliquis?
So I am going to use I am not a hematologist, and therefore I am not going to give any medical expertise on a specific medication that I don't prescribe regularly.
Okay.
Don't forget that your mics are turned off if you want to turn them back on so you can ask your question.
I asked, go ahead, whoever else that is, go ahead, go right ahead.
This is Sister Barnes. I wanted to know, after a certain age, maybe past 75, most of the gynecologists are saying that they don't want to see patients, anymore.
So I think that okay, I'm going to tell you where the issue became the issue with gynecology, with female exams. When they changed the guidelines on Pap smears, And they said women started getting Pap smears at age 21. We were still doing Pap smears on anybody who was pregnant, anybody who had risk factors, and they were finding that women were getting unnecessary surgeries on the cervix. So let's just say a 16-year-old had a really bad abnormal Pap smear. She might have needed to have a LEAP, which is a surgery that removes a huge portion of the cervix. When she became 21 and had her baby, she was having pregnancy losses. So they look at, number one, age-based guidelines. So they know that women under the age of 21 actually can get really bad abnormal precancerous cells, but their bodies fight off the cells really fast. And then they also know that with some of the mild abnormal changes for cervical cancer prevention, like your Pap smears, cervical cancer can be a very slow-growing cancer. So when they look at these recommendations, they look at the cost effectiveness, minimal intervention, catching the bad cases, and they make a guideline. So they said after 65, women don't need Pap smears anymore. Well, when people use the word Pap smear, you are just thinking, oh, my pelvic exam, my well woman. Looking at that exam, the Pap smear in itself is just getting the cells from the cervix or the vaginal cuff, putting it in a little dish, and sending it to the pathologist. When they changed the guidelines and said Pap smear every 1 to 3 years, or Pap smear every 5, or stop it at 65, even providers got this wrong. Pap smear does not equal pelvic exam. I'm going to say it one more time. Pap smear does not equal pelvic exam. And so you have a group of doctors that are even relearning that concept because they were so excited. Oh, you don't have to get an exam, but every 1 to 3 years. No. Pelvic exam is how we screen for other female-related cancers.
Right.
So you should never miss an opportunity to get a pelvic exam. Now, you also have managed healthcare who dictates what they will and will not pay for. So, for example, okay, we stopped getting Pap smears, but you still have breast. Medicaid will pay for a breast and pelvic exam at a gynecologist every 1 to 3 years. It might be state mandated, so you can find out. I have patients that say they're going to get their hoo-ha checked every year. I'm coming to see you, get my pocketbook checked. They might make that they can't deny service. So, for example, you have menopause as a medical issue, and you can go see the gynecologist. Or you have a vaginal irritation, and you can still get your exam. That's not necessarily part of preventative. Your family medicine doctor, your internist might not make that a part of your wellness, but you can say, I still want to see the gynecologist about my vaginal dryness or my vaginal itching or irritation. Because I'm telling you, you woman with a vagina, it's gonna itch, it's gonna be irritated, it's gonna be something, it's gonna be dry if you go through menopause. So you can always have a reason to get an exam.
Okay.
Okay.
Okay, thank you. You from Columbus, Georgia?
I'm from Kansas City.
I know you from Kansas City, but you work in Columbus, Georgia?
I do.
That's where I was born. That's my home.
Wow. It's a small world. You're in Kansas City now?
Yes.
Okay. Do you still have family here?
Well, just my kids and grandkids are here. I don't have family down there. Most of them passed away.
Mm.
Yeah.
Well, thank you for joining us.
Thank you so much, and thanks for the information. I really enjoyed it.
You're welcome.
All right, now ask your questions. I don't like dead time when you're doing a broadcast. She's opened up the door for you. If anybody else has anything else to say, let's feel free. Don't be ashamed. Just ask your questions. I guarantee she'll answer it. All right. Everybody's quiet.
Dr. Strozier, this is Linda again. And I asked that question regarding Eliquis because I used to work for Dr. Nevada Lee. Are you familiar with her? She was a geriatrician here
I'm
in
not.
Kansas City. Okay. So there was a process, and I'm sure you're familiar with it, where patients would do their weekly or daily INR tests. And so now that Eliquis has come up, and Eliquis is very, very expensive. And I have my own thoughts about how these medicines come out from manufacturers, and they're so expensive. And then the cost goes down after 3 or 4 years. Um, and I'll just go ahead and say it. It's just like the expectancy is there that the company knows it's going to get sued. Okay, so that medicine is really, really expensive because there's such risk associated with some medicines. And so Eliquis to me, I have no factual data or anything like that, but it just seems like that there's an outpouring that's going on now that patients are speaking up about their experiences and how it has affected them with bleeds that have been detrimental.
Mm.
So,
So, um, I'm gonna speak to medications in general, and
okay.
just a general concept. In order for any medication to be considered FDA approved,
Hmm.
it has undergone an extensive amount of trials.
Uh-huh.
They have to, so before medication even makes it to the market, it probably has been studied for 5 to 10 years without receiving any amount of compensation. And if you have multiple pharmaceutical companies or people who are working in a research lab working on the same exact compound, and somebody is able to get it out on the market faster, that other company loses those years of research on the market.
Okay.
There are people who have worked in a lab for a discovery all over the world, but if somebody publishes it before they do, and they've been working on some of these things for 10 to 15 years, it's a high suicide rate for medical research. It's a high suicide rate for bench research because people spend hours, they lose hours of their life trying to be the first person to discover something. And then as far as medications that are actually, United States has some very tough guidelines when it comes to getting your medication approved and out on the market from the FDA, the Federal Drug Administration. You have to undergo, especially we talked about how we had studies on slaves, we had studies on people of color. There are some very strict guidelines when it comes to doing medical research and pharmaceutical research. You have to have, first off, you have to go through a process on paper before you can start doing any type of research related to that medication. And then you have to do a trial on animal models, and you have to have so much time that goes by with minimal adverse effects before you can even try it on clients, on live patients. And usually there are phases that go from 1, 2 to 3 to give us the known medical outcomes, the common side effects, so that we can know how best to counsel our patients. There also are some medications that have shown benefit, but they're still in clinical trials, but there are so many people who would benefit from being on those medications. And then when medications, or let's just say a new device, comes to the market, it is considered the brand. And those other companies that have been working on an alternative, they might put out the same exact medication, name it something different. It's called the generic. But there's a patent on it that's usually 5 to 7 years. And that's why you see the decrease in costs. So basically, it does give them benefit to be the first person to come out with it. and they can maybe recoup some of those medications, some of that compensation that they've been working on for years before they can even receive any kind of profit from the work that they've been doing.
Okay.
So it's a lot when it comes to the cost of medications.
Okay.
Well,
Thank you.
I've been on Eliquis probably now 4 or 5 years. Dr. Eck here in Kansas City is the one who put me on that. But every year they have coupons where instead of me paying $90 for it, I only pay $10. So I don't know what the situation is on behalf of that.
Yeah,
So
so
now,
you have your own prescription benefits that determine the cost of where that medication might be. It may be first tier, second, or third tier. You could also use some of these good XRs. You could go to different pharmaceutical companies' website and see if there's a drug assistance program to see if maybe you can have additional discounts for medications. That's always something you can do as well.
Right. Right.
now you said about the testing, that is one of the main arguments about getting this shot for this COVID, because people are saying there was not enough time for testing.
Right. So that was a huge issue and why a lot of people were nervous about getting the vaccination. And so once they saw that there was a benefit, that patients who were getting the vaccination, they were still charting their side effects and being able to say, hey, when patients got the vaccination, these were the most common side effects at this point in time. So they looked at daily symptoms, weekly. They checked their titers to see how long they kept antibodies, and that's how they made a determination that you needed a second shot at this window of opportunity. And then looking at, they had the patient population that they were studying, the patients who got vaccinated and the ones that did not, and looking at the severeness of illness. And so this is a case in which the clinical trials are still ongoing. We don't even have enough data to say how pregnant women are we're collecting that data, but we do know that without the vaccination and women who got sick with COVID, we saw these bad outcomes in comparison to general population, that it increased miscarriage rates, it increased hemorrhage rates at the time of delivery, it increased the rate of stillborn. Just looking at the data over months or even a year, which is why the recommendation for ACOG changed from we don't know if you should get the vaccination to we recommend it for all pregnant patients, regardless of where you are in the pregnancy. So it is ongoing medical research, but when we have evidence that is helpful, we can change our guidelines based on the medical evidence-based research.
Thank you.
I think I saw a question about HPV. Who should get the HPV vaccination? Is it recommended for older women? So HPV vaccination, HPV, meaning human papillomavirus virus, is the virus that can cause cervical cancer as well as genital warts. It can also cause penile skin cancer. It can also be an attributing factor to throat cancer. And people don't talk about that because those things kind of happen later on in life when you are more prone and susceptible to viral things that can cause weird things. However, in the younger age group, it is recommended in children, I believe, starting at age 11 to 13. The recommendation initially started with girls getting the HPV vaccination. It's a 3-part series. The initial vaccination was just 2. The one that is used now is Gardasil. The goal is to get a cross coverage of it. There are 9 strains of HPV that are covered in the vaccination, and there are probably 80 different strains of HPV, but there's some cross protection for some of those. So it's giving you the coverage for the highest risk types. And initially it started out with just girls, and then it changed to include boys. And the recommended time is to get it before they become sexually active. And so most insurance companies will cover it as a preventative vaccination from ages 11 to 26. However, you can have the vaccination covered at older ages. So, for example, you have people who may have undergone a divorce or may be widowed, and they are now considering a new partner. They will be at risk of HPV because now this is a new sexual partner. Anybody who has sex with someone who's had sex, which is everybody, if you're involving yourself with a new partner and there's any amount of unprotected sex, there is a risk factor for HPV because men, there's no screening test for men. Women get tested for it through their annual Pap Smears. So a woman in her 40s, a woman in her 50s, if they are getting a new partner, they would be a candidate to get the HPV vaccination. Will insurance pay for it? It is controversial, but the guidelines have changed. And usually when the guidelines change from a medical recommendation, the insurance companies might lag 2 or 3 years before they catch up with paying for recommended treatments. But you could pay cash for a vaccination.
Now, I might have lived in the land of sheltered life or whatever. I never heard of what you just spoke about. Especially about this.
OMG. You never saw the commercial that pops up that says, moms, dads, get your daughters vaccinated against HPV, or get your children. They changed it from daughters to Gardasil. Get the vaccination that protects against cervical cancer.
I have not.
Okay, well, it's been out for years, over 10 years.
Because I have never even heard that conversation until just now.
So HPV actually has been detected in 90% of cervical cancers. So cervical cancer worldwide is the #1 form of female cancer outside of breast cancer. With the use of HPV vaccinations, it has reduced on the GYN cancer list to #5. So you have uterine cancer at the top, followed by ovarian. You have vulvar, fallopian tube, and cervical cancer. So it has helped tremendously with decreasing cervical cancer.
So it's just a virus?
It's
What
a
is-
virus that is sexually transmitted. Is the most common sexually transmitted infection. That is the most silent thing no one talks about.
Well, how does one get it?
By having sex with someone who's had sex, which is why they started vaccinating the men, the boys, because, okay, you have a girl who gets infected by HPV. She might not know for years until she gets a Pap smear that she has really bad HPV. Well, that same guy has gone and had sex with however many other girls, and now they're all just spreading HPV amongst each other.
But have they come up with where the virus came from, originated?
The origination of it, no. I don't know.
No,
Probably
okay.
somebody will say monkeys. I don't know.
Okay.
I'm gonna go back in and look and see if the history of where it originated, and I might be able to have something for you. But honestly, I don't know.